My name is Christy Foster, and I am one of the ED educators and managers at Alice Peck Day Memorial Hospital, and I was one of the leads for the geriatric accreditation process. So I work at Alice Peck Day Memorial Hospital, which is a 25-bed critical access hospital. At the time of our submission for the application process, we saw an average of 5,600 patients a year, and we had 7 beds. Since we've received our accreditation, our ED volume has increased to 11,900, and we have 14 spaces that we use. APD is also on the same campus as a independent residential home and a assisted living facility. APD is known for its culture of kindness and compassion, and we are well loved by our community, especially the aging population. Taking care of older adults in the emergency department does come with some challenges. Mostly it's upon discharge or when we are ready to send them home. Transportation back to a home residence is proving to be more and more difficult. There is not enough ambulance services or enough staff to service the ambulances, and cab companies tend to not want to take patients home that may need to use mobility aids, as it's a liability on their end, as they can't help them into their home. So this can lead to longer stays in the emergency department as we try to navigate a way to transport them home. So we are constantly looking at ways to be able to get patients home in a timely manner. Another one of the challenges, which is probably the biggest challenges that we have and continue to face in the emergency department, is arranging for specialty follow-up in a timely manner. We decided to apply for the accreditation in order to find the best ways to serve our aging population. We already know that we take really good care of patients and we treat them with kindness and respect, but this was an opportunity to develop new initiatives around best practice for this population. One of the initiatives that we implemented during the application process was creating more protein-dense, easy-to-eat food choices in the emergency department so that food and beverages were offered more frequently, which is especially important for this population if they are not in NPO status. One of the initiatives that we implemented was a campus-wide fall prevention program, which allowed a screening to be completed to identify any risk for falls. If a patient was at risk for a fall, they would be given yellow socks. Yellow socks provide a visual cue to staff so that when any patient is ambulating, that we can ensure that they have the right equipment and that they are safe while they're ambulating. Another change that we made during our accreditation process was to decrease the use of indwelling Foleys and to decrease the use of restraints. Restraints are often used when patients are facing delirium, and we created a take care kit that has fidget tools, sensory toys, lighting tools, and music options, and baby dolls in order to stimulate the patient and try to prevent delirium, which ultimately means we are not using restraints. Another initiative that we implemented in the emergency department was a referral program to the Aging Resource Center. The Aging Resource Center is a wonderful program that is free for all participants and their families to take part in free education, free learning tools, even ways to do exercise. We have added that to our after visit summary, so anyone 70 and older will receive the information either for themselves, their loved ones, family, or friends. Another wonderful program is the Mobile Integrated Health Program, which utilizes a paramedicine service. So anybody in our 2 towns in this area can receive a referral to that program, and the paramedics will come in and do either med reconciliation, they will look around and make sure they have home safety options, and provide simple wound care. So those 2 initiatives are great referral processes that have been implemented. One of the most robust initiatives that we have implemented in the emergency department was the notification of PCP, which seemed like a very simple process when we started the application process. It became very evolved and is now one of the the biggest successes from this whole process. The callback program is a way that we have created to identify patients 70 and older that are discharged from the emergency department. They will receive a call from myself or one of our teammates and to check in, make sure they understood their discharge instructions, to see if they had any questions about their stay, to make sure they have follow-up, and to help assist them with getting any specialty care or referrals. Sometimes this means getting them a PCP for the first time, and sometimes it means just helping get them an appointment in a timely manner. If I could offer any advice, it would be to pick your initiatives early in the process so that you can start gathering data, so that you can track your compliance and adherence measures, because you really want to have a good 2 to 3 months of data to show that the process and initiatives are working. I would also recommend having somebody that is very computer savvy help you with the application process. When I was doing it, it took us many times to upload the information. And I was talking a lot about cookies, and it took us quite a bit of tries. I do know that I've given that feedback to GITA, and I know they were working on it, so I'm hoping that your process is much easier. The benefits of having an emergency department geriatric accredited is the resources that it provides the patients. The initiatives that an ED picks are all beneficial to the patient's outcomes. For ours in particular, it was a lot about making sure patients have what they need post-discharge to try to prevent readmission to the emergency department or the hospital. One of my favorite stories that has come from the accreditation process occurred with our follow-up program. An 80-year-old female had come into the emergency department over the weekend with lower back pain. There was no trauma, no known cause. Her pain was 10 out of 10. We sent her home with over-the-counter pain medications and a lidoderm patch. Within a few days, I recalled her for the follow-up. The patient was obviously having a significant amount of pain. Her husband had answered the phone and said, "She's not doing well, and I don't think you're going to be able to help her unless you have a magic wand." She was able to get an appointment with her primary care for a few weeks or so from the ED visit, and she was referred to the pain clinic but wouldn't be able to be seen for approximately 3 months. The patient was in tears, so there was nothing that she could do, and the pain continued to be terrible. This was unacceptable in my mind, and so I called our associated primary care office to see if there was something they could do. They heard her story. They said, "We will absolutely see her today." At the same time, they also talked to their pain clinic, who was able to see her within a few days. When I called back, the husband answered the phone and said, "Well, did you find the magic wand?" And I said, "Yeah, I think I did." The lady got on the phone, and I told her that she had an appointment in just a few hours and that she would be following up with pain in a few days. She began to cry with gratitude and said, "I used to be a nurse, and I would have been privileged to work alongside you and your team for your kindness and your compassion." At that moment in time, I knew that the callback program was essential for my community and that we needed to make sure that we kept it as a robust program. If I can recommend one process or one initiative to really invest in, it would be the follow-up process after discharge. We often will send patients out with robust plans, but we leave it to them to have to do self-advocacy. And that is very trying, even when we are in the best of health. So finding ways to prevent them from having gaps in care, because care doesn't end at the ambulance bay doors. We all need to be part of the process to ensure that they have the lifelines they need to get to the next portion of the care that's needed. So I encourage everyone to look at what resources are available currently and what can be done to make that a streamlined process.